basic questions, and then we'll build it on those. So I'll start. Any other faculty can start. I think the first one was that how would you manage your patients presenting with a shoulder pain in different age groups? We probably can start with Mr. Nanda. And what are your signs and symptoms you look for? So GP has referred your patient with a shoulder pain.
Obviously, you take specific histories and examination catered, but there are certain conditions which are more prevalent in certain age groups. If you have shoulder pain in the young, I'm looking more on lines of instability patterns in those patients. If they are more in the middle age group, then we're looking at cuff pathologies and maybe frozen shoulder type of conditions. And in the real elderly patients, you start thinking of stiff shoulders due to arthritic conditions. So you cater your history, but sometimes you are thrown off, so you can have a 50-year-old with severe osteoarthritis. But generally, that's what it is. You think twice if you're diagnosing impingement in a 25-year-old, right? Or a cuff pathology. You've got to be very sure about that. So your history depends on that, catered towards on those lines. Your examination is based on that, and then you investigate accordingly. So it's a rough guide that how we do that.
I think again, different age groups presenting in different.
Roughly.
Anything you want to add on?
Slightly goes against what we normally do, that you're prejudiced by coming up with an idea of what it might be before you actually see the patient, but it usually holds true. My one thing I would say is that in the young patients, dislocations, although they occur very frequently, do not always cause pain. So pain is not such a major thing. So I tend to find that a lot of the young sportsmen with shoulder pain tends to be AC joint related. In the sort of 30 to 50 odd year olds tends to be frozen shoulder and or some impingement, and the older 50 to 60 mostly it's rotator cuff related, and beyond that is degenerative
Anything you do different?
From a physio standpoint, I always kind of look, there's a good concept by Adam Meekins. He breaks down a shoulder into being a stiff and painful shoulder, a weak and painful shoulder, or an unstable and painful shoulder, and you're just kind of working within them kind of three frameworks, and then just act accordingly based on that, identifying areas of weakness and what their actual goal is, because ultimately it's the goal that's the core.
Yeah. Any question?
Yeah, I have a young man, 25 years old. He plays jiu-jitsu or something, and he's a nurse, and he came to me with pain. He said the pain is on raising his arm. But when I examined him, there was no deformity, no tenderness. He had full range of movement, which was pain-free at the time I examined him. But he gave me this history, and I was unsure about what to do next. So what would you advise, please?
From by the sounds of it, he's a jiu-jitsu, which is a lot of kind of grappling, so it's obviously on the ground, and it's kind of knowing the sport as such. So when they depends on whether they wear gi or no gi, which is where they wear the kind of white kind of karate style outfit. Because if they do have gi, they kind of pull, so they kind of pull the person into them, which means it's a lot of kind of flexion biceps, long-headed biceps type stuff. And then it's just understanding in terms of his tissue loading, had he been training more and had like a big spike in his workload in terms of jiu-jitsu, or did he have a period off or with another injury? And it's kind of understanding, because they do lots of arm holds, so like where they like tap out and your arm will be in like a hyperextended position. So it's understanding if he does have any kind of past memory or past injuries similar to that.
No,
So
he didn't have any past injury. He had this injury and he had been having this pain for about 4 months. And it was only when he was raising his arm, and usually with some weight, so that because he was working as a nurse. So where should I go next? Like, what should I do for him? That's where
Referring to physio.
That's always a safe option.
Yeah, most of the times, the first port of call is to musculoskeletal services, where you have a physiotherapist who has an understanding, would assess the patient accordingly. And majority of the times, these things can be. A bit more detail about how it started, the injury is important, because sometimes they can pin it down to one particular episode, and that will worry me, especially if he's getting pain on elevation. Or Sometimes they can have a posterior instability, and you just need to be sure about that. But otherwise, it's a lot of times it could be soft tissue related or musculature related, and those are different. So yeah, from your point of view, if you can't find musculoskeletal services is the way forward,
Thank you.
and I'm sure that if they have any concerns, they'll refer it on to the surgeons.
Very good. The next thing which comes to my mind, I think again is probably from the GP's point of view as well. So somebody coming in with a shoulder and neck pain, so what would you do with them? So you obviously go to the musculoskeletal, and then they will try to differentiate whether it's the neck pain or the shoulder pain. When it's been referred to you, what would you do? Would you send them right? You need to get an MRI scan, or you need to see the spinal surgeon? Or?
There is always an overlap. You know, when I examine the shoulder, I don't forget to examine the cervical spine. So I'm sure when the surgeons examine the cervical spine, they tend to look at the upper limb as well, in case the patient has referred pain going down the upper limb. So, you know, once I've taken the history and examined the patient, it depends what I feel. I have no qualms if I feel that it is spinal related or there is a possibility of it. I may investigate that and ask a colleague to see that. But usually the musculoskeletal services are pretty good in identifying which is the predominant feature and then refer the patient accordingly. But there is always an overlap.
Any investigations or any diagnostic tests which you normally do? Or?
Again, very dependent on history and examination, isn't it? Usually for cervical spine, we tend to err on the side of an MRI scan. For shoulders, depending on what age group they are, it could be X-rays along with an ultrasound scan or an MR arthrogram.
I think the thing to bear in mind is that it's very rarely one or the other. It's usually both, and I think it's a matter of trying to work out which predominates. My approach to it is the patient may have a significant shoulder problem. If with movement of the shoulder of the arm, the shoulder hurts, that actually tells me the shoulder is a major problem, and then that's the one thing that I can manage for that patient, being a shoulder surgeon myself. So that may be taking the form of diagnostic injections, therapeutic injections, or further investigations for other work. Obviously, from the neck viewpoint, we look for the red flags, you know, the numbness, the weakness, and we'll investigate accordingly, like what Rajesh said earlier.
About the shockwave therapy for tendinopathy of supraspinatus, how does this work in the NHS? Either if the physio is referring if failed, or the shoulder surgeon is referring that, or there is no rule?
In private practice, there's kind of no rule as such, but within kind of actual NHS, what we normally do is make sure that they've had like a 12-week loading program for any type of tendinopathy type conditions, loaded for 12 weeks with the appropriate progressive loading. And if they're still not kind of making the improvements that you would expect, then you would kind of refer in for shockwave therapy.
And how's the success rate of shockwave?
Have you ever had it? It's pretty uncomfortable. It's like a little mini jackhammer. But yes, it kind of does stimulate. I don't know what it is. The theory behind it's still a bit kind of iffy at the moment. But it does actually kind of lead to some good improvements, as long as they've done the loading program prior to that as well. But if they haven't done any kind of sufficient loading program, it doesn't really make much difference.
So the physiotherapist is referring?
Yeah.
I think that would be different across the country, isn't it? Depending on what your arrangements are with the local CCGs. And I think those controversial questions will come at the end, because there are quite a few controversial questions at the end. So the next, for first-time shoulder dislocation, I think they will again, as Mr. Nanda said earlier, that look into the patient's age. Anything you different when they've been referred to you then after first-time shoulder instability?
Again, kind of clearing red flags, make sure that there's no kind of neural type symptoms associated with it as well, and then kind of looking what their long-term goal is. Is it to get back to a specific sport, and then kind of also just starting off with kind of like low-level closed chain control exercises. So kind of thinking about neurodevelopmentally, how we develop as children, kind of 4-point kneelings where you develop shoulder stability. So that's where I'd kind of start the rehab with them.
And at the moment, either Mr. Nanda or Mr. Dea, are you doing first-time stabilization after first episode?
So, there's a very good best BOA guidelines for first-time disc acute dislocation of the shoulder. I think everyone should have a read about it. It's dependent on the age group as well. If you're very young, then you're looking at labral instability, shoulder instability due to labral injuries. If you're very old, then you're above 40, you're looking at those shoulder instabilities due to cuff pathologies, associated cuff pathologies. So you've got to differentiate between the two. My usual practice is I follow first-time dislocators very closely. I do send them for rehab, but I see them again and reassess them in about 6 to 8 weeks. And if there is still any signs of instability or they're still symptomatic, I will go ahead and stabilize them. But if while waiting and they dislocate the second time, then it is a definite stabilization in my books. Obviously, we'll investigate them accordingly based on that. Raymond leads on a one-stop clinic as well in our trust for shoulder dislocators.
It's a clinic that we've set up recently for first time for shoulder instability, because I think we're seeing a lot of patients coming into our unit with shoulder dislocations and then being sent to rehab physio, redislocating again, going back to rehab and physio, and just going round and round and round without any definitive treatment being offered. I'm a bit more aggressive than Rajesh, I must admit. I think I find that under 25s, first time dislocators most likely will redislocate again sometime in their lives, and for that reason I recommend primary stabilization in active individuals. Obviously, in older individuals, like Rajesh said, it's looking out for other shoulder injuries. Pretty much like what I mentioned in my talk earlier, to look out for the other peripheral shoulder conditions that can be associated with this trauma.
Very good. Now a couple of probably difficult questions for Darren now. So, somebody with the shoulder instability, they've been referred to you. Is there any easy way to identify muscle patterning?
Muscle patterning, so again, you can do all your standard kind of testing, check your apprehension test and confirm that there is that instability. And then kind of from a muscle patterning standpoint, a couple of key things is looking actually from kind of like any skin folds from their lats. So kind of that's where I kind of normally look at, and kind of in terms of any other kind of hip hike, any altered kind of shoulder positioning, and if there's any asymmetry, I'm kind of looking from that point of view. There's loads of good work done by a lady called Jo Gibson, who's kind of like quite a well-renowned kinetic chain shoulder specialist, and she advocates the second someone comes in with any shoulder issue is you get them kind of working quite hard from a lunges, lower limb control, strengthening point of view, lunges, squats, and then slowly integrate kind of some shoulder rehab on top of that as well.
In simple terms, if somebody's not aware about muscle patterning, just briefly, how would you describe, or how would you?
So muscle patterning is just kind of looking in terms of, right, is it a flexion-based pattern that they're struggling with? Is it a kind of more abduction-based, so flexion-based stuff more indicate more of a bicep side of things and dominance?
It's more the effect of muscles on the controlling the shoulder stability.
Exactly. And then you're looking at the primary movers within that muscle pattern. And again, there's always going to be a little bit of overlap, and it's kind of sometimes quite hard to differentiate. But if you have a dominant weakness in one pattern, that's where you can really focus your attention.
Want to add anything, sir?
All patients who have a shoulder condition will end up with some kind of muscle imbalance. It's seen more commonly in patients who dislocate and are treated inadequately. Then you can have one set of muscle groups predominating and the others not doing very well, and they get this kind of a abnormal scapulothoracic movement, abnormal muscles which are contracting and relaxing at different times, which leads to a sensation of instability.
So I think that's important.
After dislocation, it's quite common if treated inadequately, but there is also a group of patients who've never had a former dislocation, but they, for some reason, develop this kind of a muscle patterning, which they tend, I've seen more in patients who have hyperlaxity as well, and they tend to do that. And if you go by the famous triangle that we all use, the Bailey's triangle, majority of the patients are eventually end up in that muscle patterning group if not treated adequately. You need to identify them first and then treat them appropriately.
I think that leads on to the next question. In the patient with hypermobility, have you noticed any, for Darren, so have you noticed any difference in the rehab? So again, is more the muscle patterning is more of an issue for them for the rehab?
Yes, kind of with hypermobility, it's 90% just looking at the kind of motor patterning. ones because it's a widespread kind of control issue.
Is it the more kind of proprioception associated with muscle patterning, or both of them you keep them as a separate entity, the proprioception, the hypermobility patients, along with the muscle patterning, or they are interlinked?
They kind of overlap and interlink quite a bit. I always compare it to kind of trying to shoot a gun off a boat. If you have an unstable surface, you're not really going to hit your target.
Right.
And essentially with the kind of the shoulder and the hand, if you're trying to reach for something and the shoulder doesn't have that point of reference, it's not really going to kind of move optimally. So kind of that's where I kind of normally focus on from the hypermobility standpoint, and giving it like an isolated awareness, then integrated into a functional movement that they're struggling with, and then kind of lead on to whatever sport or whatever they do.
Any further questions on shoulder instability? As you might have noticed, that we started with the shoulder. We discussed about the shoulder pain and then the shoulder instability. Now we're moving on to the further other topics. Any questions about the shoulder instability?
Multi-directional instability. What's your treatment protocol?
So I think it's important to distinguish between a true multidirectional unstable patient as opposed to someone who's lax and multidirectionally lax.
Yep.
Okay, so when you're talking about instability, they need to be symptomatic in multiple directions for that label to become true. So those are pretty rare.
Yep.
I think most that we see are people who are lax with one direction of dislocation. In those with multiple dislocations in different directions, then obviously you need to address each separately. But of course, you know, the base to start with is physio, and to make sure that they've got the ability to control their muscles, to control their shoulder movements, and to protect it. And once you've got that, or at least some inkling of that, then you can address the pathology.
There was a review article from Robinson, so I think it's a very important point that you identify multi-directional instability. But if the multi-directional instability is after trauma, and if they've got a lesion, then you will treat that as part of a multi-directional. You can't just send them on all to physio and say, right, you've got hypermobility, you've got multi-directional, you just go out. If they've got a structural abnormality, then you need to correct that and then focus on the multi-directional issue.
Patients with generalized laxity who are unstable in all directions are a different entity, and they seldom seem to have a structural abnormality. But usually the multidirectional ones that I have seen are who have either an anterior and an inferior or a posterior and inferior. It's very rare to see them anterior, posterior and inferior, depending on the injury pattern. So we tend to then deal with them. So when you examine them, you see the sulcus sign is positive when we pull the arm down, and we say, well, that's multidirectional instability. But actually we're testing only for inferior instability along with the anterior or a posterior pattern. So it's likely two completely different entities, and like Raymond said, we label them wrongly. We just call everyone with one big brush stroke, so they're very different.
I think that the problem with the literature is that, again, multidirectional, if you got anterior after an injury and you got hyperlaxity and you got inferior laxity, they've been classified as multidirectional, but that's not a true multidirectional instability as compared to if it's coming out everywhere. So that's very good. Yeah.
About the neglected dislocation or the heavy drinker, which comes with dislocation after a month or a couple of months, how do you manage
Those are quite complex, and we do get a few of them each year. It depends on the duration of the neglect, essentially. So if the injury is quite long-standing, then it becomes quite a difficult issue. You tend to find older folks with neglected dislocation, and for those, if they're confused, then there's not very much that we can do about it. In the younger people, those that have been missed in A&E, then obviously we need to treat the pathology. Mostly, I think if it's out for a week, chances of a close reduction is going to be quite possible. So you have to move on to an open reduction. Once you reduce it, you need to keep it in. So obviously you have to do things to try and address that. So there are multiple ways of doing that, and we have our own approaches. The main thing is to get balance of the soft tissue, to make sure the soft tissue are properly balanced, such that the restraining structures at the front, and this is mainly anterior, the restraining structures at the front are stronger than those at the back, so it doesn't fall out, and to address any bony lesions.
Very good. So I think we'll probably just briefly touch on the impingement. So any role, so I'm going to ask you about your pathway or how you manage a patient referred to you by the GP with shoulder pain, suspecting of impingement. do you normally get, if you do not have a suspicion of cuff pathology, would you get an ultrasound scan routinely or you won't?
Not necessarily with myself. When I see them, I kind of, if I feel it's an impingement, try rehab first as a first line of approach. If it is a case that their sleep's affected and they're kind of functionally kind of quite limited at work, then that might be an indication to refer on a bit quicker than it would normally.
And then the injections, would you give injection, and if you do, then what do you give? How much the volume in which?
Again, for the first part, usually the patients who are referred to us with impingement have had a lot of physiotherapy or some treatment. We tend to do a one-stop shoulder clinic. We have easy access to X-rays and ultrasound scans. So if clinically we suspect, we will get both these investigations done in the same sitting. If I feel that this can be managed conservative if the patient's okay with it and I want to go down the route of an injection, I do high volume, high concentration. So I put 8 mils of 0.5% Chirocaine with 80 milligrams of Depomedrol if the patient is fit and healthy. So yes, high volume for me.
With impingement, I like to know that the cuff is intact firstly. So and there are several ways of investigating that. X-rays, I think plain X-rays, it doesn't tell you about the cuff, but it tells you the bony structures around it. So I mostly like to see some X-rays. And I think an ultrasound scan is quite important because that will actually determine if the cuff is badly torn or not. And I mostly will not counsel an injection until you're sure that the cuff is not torn. Because a torn cuff with steroid bathing it is going to become even more unhealthy.
Right. Either of you use any biologics at the moment in the shoulder? Either in NHS or other sector?
Biologics as in...
as a treatment in the shoulder.
So you're thinking of things like PRP?
So
PRP.
PRP is one example.
I don't routinely,
No.
and I don't think the evidence is strong enough to support that.
Okay. And Darren, if you have any patients who have the PRP or any biologics treatment in your practice?
I haven't seen too many of them come through, to be honest.
I think if you have, then the question wasn't if you noticed any difference in the rehabilitation, but I think we wanted that question. Very good. Okay. Right. Okay. Now, a middle-aged man referred to you with rotator cuff tear and degenerative changes. Do you, I believe there were use of graft jackets and in-space balloons for those patients. Are you still routinely using them, or they're just part of the studies now?
No, I think these are very individualized cases. It depends what it, when you say degenerative changes, is it degenerative in the cuff or is it degenerative in the
Both.
bony architecture? Obviously, it depends a lot on the age of the patient, activity level of the patient, biological age of the patient rather than more chronological age.
That's important, the biological.
Yeah, and the activity level of the patient and all those. The person who we deem as young and active, you tend to be more aggressive to try and repair it in whatever way we can. Whether it requires a graft jacket interposition or reinforcement using that, we'll go ahead and do that. Balloon interposition is a salvage for pain relief only, so that you can rehabilitate the deltoid. That is reserved more for the slightly older age group and less active patients. And yes, at the moment it's part of a study, so we are doing that. But those are far and few in between that we use. So it's very individualized.
Yeah.
Can I just clarify? You mean degenerate as in glenohumeral arthritis?
So I think So again, I think the glenohumeral arthritis is secondary to whatever else is happening. So they've got a degenerative cuff tear, which they've been living for some time, either ignored or probably wasn't symptomatic enough, and then they ended up with a degenerative cuff tear large enough that you can't repair, and then they have glenohumeral.
Sure. I think my attitude is always to repair the cuff if I can. So even if there's some degeneration of the glenohumeral joint and it's congruent, it's actually moving quite well, and if the cuff is repairable, that's probably the best best way to go, get it repaired, and mostly they do function quite well. If of course your degeneration of the joint is so bad, the arthritis is so bad, it's an incongruent joint, very, very stiff, doesn't move very much, then there's no point trying to address the cuff. If that's the case, then address the arthritis.
Good. Very good. Okay. Now, probably some controversial topics now. Okay. So this is probably the first one is not that controversial. So do you see any role of 3D bioprinting in the future, maybe 10 years, 15 years down the line, maybe earlier than that?
Well, we're doing it now.
Mhm.
So in cases where we have, for arthroplasty, where we need to know about the glenoid architecture and getting some specific guides for that, we are using 3D printing at the moment. It's not commonly used, but we are.
Yeah,
Yeah.
PSI for instance.
So the bioprinting, I'm thinking more towards growing cartilage or putting a bit of cartilage
Okay.
or put a
that
bit of
way.
labrum.
Oh, no.
Where do you see it in 10 years? Do you think there's a role for that,
Well,
or is it going to
Yeah,
be
I
coming?
suppose tissue engineering is the next way to go, really, isn't it? And I think it's one way of developing kind of biologically active tissue. Half the stuff that we use at the moment are kind of salvage material from donors, or lab prepared, or
So,
either the patient's own or allografts. So I think obviously tissue engineering has a role. Whether it will give structures robust enough for the purposes that we want to use them, that remains to be seen. And I think that's where the industry's got to improve to.
there are a few centers who are using the Macy, our technique for cartilage regeneration in the shoulder. It's not yet common use.
Thank you. Right. Now, any role of ultrasound scan in the management of patients in the physio, in the rehabilitation?
Ultrasound, no.
No. Okay. TENS.
Simple no, throw them out.
TENS.
Well, I'm surprised there because some of our physios swear by it, and we get patients back saying, "I've had ultrasound therapy, and whether it's literally on the shoulder or between the ears, they seem to be cured, isn't it? Or
I
they're
think it's
happy
all in
about
the
it."
mind, isn't it? So it's all
It may
patient's
be.
perception of what's going to
Patient
work for them.
perception.
It's a passive treatment where they go around and potentially have that communication, which is the
Right.
actual treatment.
It's the talking therapy which
Yeah.
works probably more than the ultrasound therapy, but
Yeah,
I don't say no to them like that. If the patient's happy and the physiotherapist is happy, we let them carry on.
And sometimes it's a case of the patient won't engage with the talking therapy per se, but if they have another adjunct, they'll attribute the success to that.
makes sense.
Sugar pill.
Do you, for the degenerative conditions, the degenerative tendinopathy, do you use the GTN patches, or is there got any role, or have you stopped using it?
Not particularly, no.
And there's something I was looking in the literature, the restricted blood flow. I don't know, so restricted blood flow for the upper limb, for the lower limb. Is this something which is going to be in the horizon, or is it just kind of more?
Yeah, there's a lot of research being done in it at the moment. Kind of originated from Japan, I think. Where it's started kind of doing like a lot of blood flow restriction around quadriceps, and then you do a specific kind of rehab protocol, and it has some evidence about growing hypertrophy in the muscle. From a shoulder perspective, the hypertrophy is not the main issue as such. It's more the kind of functional strength, but for lower limbs, I can imagine being used in the future.
The cryotherapy or the hot and cold baths after the shoulder, after any kind of injury, do you normally use them in the practice as well, or is it just the elite sports people that just jump into the cold
Yeah, I
bath
definitely think
afterwards?
there's definitely a role for it, and I'm on the same kind of wave as if the patient finds hot or cold helpful.
If they're happy, then just let them do.
These are all good treatments when the structural integrity is maintained.
So that's important.
Once the
mention.
structural integrity is lost, then these things will not help you.
Very good. Okay, just one more question on the shoulder. When would you allow your patients to return to sports? Now again, that's after stabilization.
But again, individualized. It depends on their level of sporting and what kind of sport they're involved in. But I don't think there's a rule of thumb, but usually we allow them to progress into activities by about 6 to 8 weeks. But if they're into sport, which is a contact sport, they start with the training aspect first before they go into sports.
And with, Mr. Neil?
Well, I think I look at the healing timetable for the structures, and I think you'll find that most healing tissues complete their kind of consolidation by about 3 months. So, you know, you will need to set something going before that time, because otherwise sportsmen will lose their strength, their ability. So, you know, I mostly permit them, you know, to get back to their cardiovascular work as quickly as possible, because there's no, you know, that shouldn't affect the shoulders. But in terms of shoulder function, in terms of taking impact, I usually delay them until about 6 months. I think that's pretty standard.
3 months or 6
amongst.
months, but depending on the activity level.
Well,
Yeah, exactly. It depends on the
start,
sports
yeah,
that
you
they
start off,
participate
so
in.
they can start off doing the
Correct.
rehab bit early.
I think
and
the
then-
rehab something that,
And the contact bit is late.
and the important question: how would you monitor their progress? Are there any special tests? Or you do strengthening check or control, or what do you check before you say right now, I think you're okay to go?
Yeah, so I kind of essentially sport, you have to prepare them for the worst case scenario. So whatever the worst case scenario with respect to that sport is, you need to almost see, are they ready to get to that stage in a controlled environment, and then kind of see from there. But I'd be the same kind of in around that 3 to 6 months time, and go through a battery test depending on their respective sports, make sure that they're able to deal with kind of contact, non-contact stuff, and kind of some high loads, and then breaking it down whether it's an endurance component or if they have any like strength deficit, speed deficit, muscle reactivity deficit, or an endurance component or a power component.
So it's much more detailed assessment of what exactly they wanted to do, rather than like you're allowed to go back to sports.
Yeah. You have to
I
deconstruct
think,
it down.
I think it's quite important to work with your coaches as well.
Yeah,
So,
definitely. That's the key.
Yeah, most elite sportsmen will come to us with their physiotherapists, and
We'll have a
we
list
have
of-
the club physio with us, and they are the best people to judge, because they will understand the level of performance required.
Very good. We're coming to the last part now. So you mentioned about the PRP, you're not using it. Steroids, if you use the steroids for any reason, then would you delay your surgery after that for a few, would you delay it first of all, and if you do, then how long?
I tend to delay any surgical intervention if I'm given a steroid to the part for at least 3 months.
3 months.
Whether there is any scientific
I think it's
basis
8
to
weeks
it,
is
I'm
probably
just
fine. I think most patients that you see in clinic will have this steroid flushed on their system by 8 weeks. You know, if they're going to be recurring, they recur at about the 8-week mark. So
I think again, I don't think there are any studies in the shoulder, but I think again they've looked into the knee,
knees.
having arthroplasty further on. But I think again that was the minimum.
3 months is what they do, so I just tend to stick.
Same for actually rehab as well, make sure that they do have a period where if they do have an injection for 72 hours, cut down the rehab.
Okay, very good. Just to touch on the painful elbow, what would you? So obviously you made GP's been referred to you. So the patient has got the tennis elbow, they've got the other side, the golfer's elbow, what you call it. At what stage? Obviously they had their pain because they have rehabilitation. What would be your indication that now they are a candidate for surgical intervention? Is there any test which you do, or is it just a clinical examination, or failed conservative management?
From my point of view, surgery is last resort, and I try and dissuade them for as long as possible. Most of these conditions are self-limiting ones, and they should settle down. But failed conservative management is something I would then recommend if the patient is really, really keen to go down to surgery, doesn't want to wait. Tends to be, in my practice, more the patient demanding it rather than me offering it.
Okay. Anything different? So, yeah.
much the same, really. I think I manage it as a nuisance, and I tell the patients it's a nuisance, and it's something that will get better on its own. It's just how much they can live their lives whilst the symptoms are present. So yeah, conservative treatment is crucial. I do believe in steroid injections for this. I believe in physio, and I think it's quite important to ensure that the muscle tendon unit are stretched and kept as long as possible. Most of these actually recur because they keep their elbows flexed, and then every time they move it, they stretch out the healing structures, and hence provoking that chronic inflammatory process. So my approach is to manage them conservatively as much as possible until the point where symptoms just gets in the way of their lives.
Then again, no, at the moment we're not routinely using the biologics, any PRP or any other things at the moment. Okay, now coming to the wrist now. So somebody coming with the wrist pain, and again they're not sure. So it's hurting there, it's hurting there, it's hurting everywhere. So how would you differentiate? Is it kind of again based on the age group, or based on the nature of the pain, or based on the location of the pain, or kind of combination of everything?
Has to be everything, isn't it? So history is very important. You know, if they're young and with sport injury or just proper history of injury, you go down that route. If it is more in keeping with the degenerative fossa, which is likely older age group. Wrist is complex. It's not just wrist. It can be anywhere from the bony, which is DR, distal radial ulnar joint, the actual radiocarpal joint or the mid-carpal joint. Whether it is ulnar side or radial side, then you have the soft tissues around it, and then you have the bone itself. You know, in the young 25-year-old lady who comes with wrist pain for no reason, all of a sudden my alarm bells start going. Am I going to miss a keen box there? So things like that. So it's a far more complex thing, and wrist pain per se is a huge topic there. So yeah, it has to be a very detailed history. And examination, because it could range from anything from instability of the joints, bony problems, or tendon, which could be snapping also.
Complex.
It's a very complex. And so, you know, some of our colleagues will have a complex wrist clinic with
Right,
4
okay.
to 6 patients in a 3-hour clinic, because they know it's going to be problematic. So that's how.
Anything different?
So I'd be pretty much the same, kind of make sure age dependent, kind of is it a stiffness restriction in any specific pattern, flexion extension, and then kind of working down through your Kaltenborn tests, with carpal bones, seeing if there are any restriction in specific bones, and then kind of the younger population thinking, right, is there any significant change in their routines, hobbies, activities that potentially could have led to some tendinopathic changes within the muscles in the wrist. And that's kind of where I go from there.
Last question from all of you. So, what pathology not to miss? First of all, start with shoulder. Just one pathology. The one our GP colleagues or physios or anybody in the general public after either injury, not injury. One pathology not to miss.
That's something that will destroy the joint early, isn't it?
So
or anything with red flag signs, like if you're suspecting infection.
So infection from you.
Yeah,
Okay.
absolutely.
Anything?
Something that commonly see missed after red flags is always a priority. Would be kind of any like radial nerve type irritation. So
Radial
again, it would masquerade as kind of shoulder type symptoms and kind of radiating down, but
Anything with stability, instability, Mr. Yao?
Get them stabilized early, is what I say.
But
Because
again,
I do get a lot of very, very complex instability, and I think a lot of them are actually not managed well early enough. But I will also say that I strongly believe that rotator cuffs should be repaired. I think rotator cuff tears should be repaired, and I think it's highly common. It's much more common than shoulder instability, and it's morbid because it will give rise to pain, it will restrict activities. In time, the patients may get less pain, but there is still some restriction to what they can do, and they will degenerate. So I strongly believe in managing rotator cuff tears well.
I think that's important. So, one of the take-home messages should be, if a person is dislocated twice, it has to be surgical cure for them.
you can't just keep referring
Yes,
to guarantee.
exactly. So please make sure
No more physio.
that patient is sent to us. If there is a cuff tear in the young, 79-year-old with a cuff tear, we can leave alone. But if it's, well, mostly.
do you
But
have a cut-off restriction on your age?
there is no. It's look, it's
Physiological.
I
Well-
had an 80-odd-year-old just a couple of months ago who turned up to my clinic in his leathers and was really happy because he could go fishing again.
Very good. In order to avoid posterior dislocation, I think they're working with you. I think I've seen a few of those. And again, it's not the general practice. It's the hospital, and we miss it as well. So, what would you suggest? A quick, easy thing not to miss.
Posterior dislocation is clinical examination. They can't externally rotate their arm. Their arm is stuck like this. They can bend it and they can do stuff, but they can't externally rotate. It's a clinical examination is important in that. And actually, this moment I have a posterior dislocation waiting to be operated, which has been missed. So it is a very commonly missed one. We do see about 3 to 4 a year which have been missed.
I again, we don't go into the details about how to manage that because obviously that's a
Yeah.
different debate. Any question you want to ask before we close this?
Can I
session?
just add, you can always just get the patient to sit down, look downwards, and look at the shoulder, and with posterior dislocation will be recessed. It's very easy to spot.
Maybe the
Any
frozen shoulder coming with the same external rotation, how to differentiate?
Yeah, that's a good question because the frozen shoulder is also the stiff shoulders. Any stiff shoulder should be examined properly. Obviously, the frozen shoulder patient will give you a definite history of things going on for a few months by the time they come to you and all when they get stiff enough. So yeah, they can keep their arm and they lack external rotation, both active and passive. Usually they have a bit more jog of movement. Similarly, severe arthritic shoulder can also mimic a stiff shoulder with lack of external rotation. But a posterior dislocation patient usually will give a history. Sometimes they don't give a history because they've had an epileptic seizure and they could have had that seizure in the middle of the night, and this is a patient of mine who was missed. He was sleeping, he got up in the morning with aches and pains all over and was missed because he had a seizure at night. So yes, it is possible, but it's a clinical examination. Like Raymond suggested, if the patient is lean enough and you look at it from the top, you can see a bit more prominence at the back. But again, it's a clinical examination. If you're suspecting that, then you will x-ray it accordingly, and it shouldn't be missed. 2 views at least, if not 3, for every shoulder.
Right, very good. Thank you very much for all the